So, when and how to discontinue the antidepressants in order to minimize and prevent, whenever possible, the chance of the so-called antidepressant discontinuation syndrome. We know that depression and also anxiety are among the top causes of disability worldwide, both in terms of years lived with disability and the years of life lost, which account for the daily index. Depression and anxiety represent the most common diagnostic target driving the prescription of the antidepressants, which is unsurprising. And as I said before, depression and anxiety are among the top leading causes worldwide for pardon and disability. And this is also rising over the recent years. However, the antidepressants are widely prescribed also to people with conditions other than depression, including migraine, chronic pain, fibromyalgia, ADHD, eating disorders, smoking cessations, and possibly more. This means that a quite relevant number of people worldwide may be exposed to the antidepressants. And let me say something that should be relevant for this presentation. There's no need to consider the antidepressants harmful unless this represents something that is not part of a rational prescription. I mean, there are many patients that are required to receive the antidepressants, and many of them may require long-term therapy in accordance with the international treatment guidelines. Not every depression is the same, so different major depressive episodes may be treated with different treatments, not just pharmacotherapy. And by the way, not all the major depressive episodes may be treated with antidepressant monotherapy. This is with special reference to people who endorse depression within the course of bipolar disorders. No matter what, most doctors have no exit strategy. They do prescribe the antidepressants or any other kind of drugs without planning into advance how to discontinue and when to discontinue. The process of the discontinuation of any prescription drug should always involve the patient, who is the final recipient. But in the clinical reality, many prescribing doctors are pushed to prescribe, and just a few patients are actively involved in the process of antidepressant discontinuation. One of the reasons for antidepressant discontinuation is obviously related with the lack of efficacy. So, people failing to achieve response after 2 or more adequate trials may be perceived as treatment-resistant depression cases. So why adequate if not really leading to response? Well, adequate is more about the average dose and the length of the exposure. So it's something that should be expected to be adequate, so able to lead to the achievement of response in the majority of patients with that clinical features treated with that average dose for that length of time. But not everybody is going to respond, and there are many different reasons for that, including psychosocial factors, general medical or other psychiatric conditions, comorbid with depression and treatment adherence, and many other. So it should be a sort of pseudo-treatment resistance in some instance. Well, there's also another possibility that the antidepressants do work and then they stop to be effective. This is quite unlikely in the clinical reality, but still it has been documented. Treatment emergent adverse events, including affective switch, are part of the potential outcomes associated with antidepressant monotherapy, even among people who have been diagnosed as major depressive disorder, so unipolar. Well, chances are that some antidepressant drugs may interact with other medications and those require to be discontinued or adjusted in terms of doses. Changes in insurance plan coverage special scenarios, including children or women, childbearing potential, who get pregnant. By the way, this is part of the topics covered in the literature, beyond the present lecture, and even for that scenarios, the rule should be slow tapering. But we will go back to this issue in a matter of few slides. But no matter what, many patients do abruptly discontinue their antidepressant medication early, and in a few cases they let know the clinician about this. Many reasons account for this, and the leading cause is lack of adherence. So proactive involvement of the patient with education plans and is the rule. So this is a recent paper appraised in the Lancet Psychiatry. It's about the efficacy and acceptability of 21 commonly prescribed antidepressant drugs. On the left end of the slide, you see the network for efficacy, which is not really the core of this presentation. Still, I included this in the slides for consistency issues. While on the right hand of the slide, there's the network of the comparisons made to account for acceptability. Acceptability basically means discontinuation due to any cause. So the bigger the sample size, the bigger the cycle. You see that placebo is the biggest one, and this is unsurprising because many comparisons are done against placebo, or may alternatively be done with active intervention against each other. So when you see the different segments, you see that the thinner ones are those that involve less comparisons. And the opposite is also true, obviously. The main message with relationship with discontinuation, actually, or withdrawal, we will go back even to this issue, differential terms, is about the withdrawal risk. Actually, it's an odd ratio in this case. But anyway, in plain English, odd ratio means that when it exceeds 1, and you see this on the right side of the forest plot here, on the right side of the slide, when exceeding 1, this means that the drug is less favorable than the comparator, which is placebo in this case. On the other side, on the contrary, when the odds for this outcome, which is acceptability again, is below the null value 1, this means that drugs like agomelatine and fluoxetine are less likely to induce withdrawal against placebo in the acute treatment of major depressive disorder. You see that the tricyclic antidepressant clomipramine is the one that is associated with the lowest acceptability profile. Anyway, you have the point or the ratio here and the credibility interval. So when it crosses the null value 1, like in these cases, many cases actually, you can see this from the plot or from the range of values, this means that it's a non-statistically significant value. So the most reliable overall information here are those regarding agomelatine, fluoxetine, and clomipramine, because it's 0.01, the lower bound of the credibility interval. So let's go to more clinical topics. So what antidepressant discontinuation syndrome is? Not everybody who is going to discontinue the antidepressant will experience the so-called antidepressant discontinuation syndrome. Not everybody, absolutely. And even those that will endure symptoms like the Finnish ones are those that may present this with different severity and for different lasting time. So there's a lot of variability in terms of severity and length of the duration of these symptoms. Most of the symptoms are related to neurovegetative activation, including flu-like symptoms. So this may also include GI disturbance, including diarrhea, insomnia, nausea, imbalance, sensory disturbance, including the recruitment phenomenon. So people is more sensitive to the environmental noises. Hyperarousal is part of the picture with inner tension, agitation, anxiety. Additional symptoms may also apply. No matter what, the antidepressant discontinuation syndrome and the related phenomena with special emphasis to antidepressant withdrawal are reported in the literature and are a matter of increasing interest within the past years. The DSM-5-TR, the very recent revision of the text, which was released to the public in February 2022, acknowledge a chapter which is medication-induced movement disorders and other adverse effects of medications. And there is a special reference to antidepressant discontinuation, which may occur following the treatment with all types of antidepressant. Also, the incidence of the antidepressant discontinuation depends on the dosage, the half-life of the medication being taken, and the rate at which the medication is tapered, which is part also of the common clinical sense for most clinicians. As a prescribing clinician, I do prefer to slow taper, but I will comment further in a few slides. No matter what, we need more prospective longitudinal studies. In 2019, a very relevant review, systematic review, apprised in the Journal of Addictive Behaviors. The review by Davis and Reed, who are based in the UK. Other authors, including Iacobucci, echoed the impact of the findings from the review by Davis and Reed, and basically they found that more than half of the patients do endorse symptoms that may be considered part of the discontinuation withdrawal realm. So most of them, almost half of them, may describe these effects as severe. And most importantly, these effects may last much longer than clinically expected by most clinicians. So some sources state that these symptoms may last for weeks, months, or possibly years. As a clinician, I'm quite skeptical about this statement. Anyway, it is something that should be backed up both with the clinical experience against the evidence-based literature. So this kind of evidence, which is a summary of the evidence at the end of the day, should have prompted the international guidelines to be amended and updated to reflect this. This is what happened to the UK NICE, the National Institute for Health and Care of Excellence guidelines, which was freshly amended to reflect the fact that the medicine associated with dependence or withdrawal symptom may lead to pictures that may substantially vary across different patients, but may last much longer than expected before. There are different rating tools to address and try to rate the severity of the symptoms. Among others, here is one dating back to the late 90s by Gerald Rosenbaum and his colleagues at Harvard. This is the discontinuation emergent signs and symptoms, the DAS. There are multiple ratings and instruments about this. What are the diagnostic criteria for SSRI and SNRI new withdrawal symptoms? Well, as I said before, there are possibly more additional tools that may be adopted in the rating of discontinuation or related, in these instances, withdrawal phenomenon. And this is one of the many. This is endorsed by Chouinard in 2015. And this is interesting because they provide an in-depth description of the phenomenon, and they also take into account for the SNRI. So Most of the evidence is currently based on the selective serotonin reuptake inhibitors, the SSRIs, and just a few reports are about the older generation antidepressants, including the TCAs, so the tricyclic antidepressants, the MAOI, the monoamine oxidase inhibitors, and just an emerging evidence is about the serotonin norepinephrine reuptake inhibitors, the SNRIs. So virtually any antidepressant is a potential source for this kind of phenomenon. At the end of the day, the network meta-analysis about Cipriani has almost excluded this kind of outcome for agomelatine, and also for fluoxetine, which, by the way, is necessary. And interesting enough, fluoxetine is the SSRI with the longest half-life in the SSRI class. This is in sharp contrast with the SSRI paroxetine, which has the shortest half-life in the SSRI class. Here are different definitions that I consider relevant for the theme at review, and I will stress out the fact that withdrawal, which should not be used interchangeably with discontinuation, is more about a reaction that features the reemergence of the representation of the initial symptoms, also of new ones. This is one of the special issues about withdrawal. We should not be confused with relapse of depression, which is the return of symptoms satisfying the full syndrome criteria for an episode that occurs during the period of remission, but before the recovery. I will comment this further in a matter of few slides. So you have a very, very essential reference list here for each definition, and additional reference is provided by Schwinard and Schwinard, 2015. So what's the difference between the American Psychiatric Association, the APA, and the NICE with regard to the discontinuation, say, withdrawal phenomenon? Well, at the end of the day, the American Psychiatric Association also updated the clinical practice guidelines for the treatment of depression across 3 age cohorts. This was done recently, and in February 2019. But basically, the APA is still retaining the concept of discontinuation, and other sources, especially Davis and Red, also the Fava and collaborators, basically say that this kind of approach may underscore the severity and the duration. They use the term withdrawal rather than discontinuation, but still of this kind of phenomenon. Additional reference at the bottom of the slide. How to recognize and ideally prevent or anyway manage the antidepressant discontinuation syndrome. We know that there's some sort of classic pattern, the cluster of symptoms that were portrayed in the Finnish acronym, but these symptoms may vary, and sometimes they also encompass extrapyramidal symptoms, hypomanic mimicking states. This is not that frequent, especially with reference to the EPS, but still may occur, especially considering that abrupt discontinuation of the SSRI drugs, which feature high potency, so low Ki occupancy of the postsynaptic 5H2A receptor, may somehow reduce the dopaminergic activity also in the striatum, and this is one of the potential explanations for the EPS. Hypomanic switch or dysphoria or inattention are something that should be very, very relevant to recognize also in order to prevent impulsive behaviors or possibly even suicidal behaviors. And when we see patients with this kind of outcomes, we should be alert and consider this as part of the soft bipolar realm, or possibly bipolar patient. No matter if this was a mood state induced by the drug, they are more sensitive to these drugs. So this is the clinical reality. So, again, as I said before, the antidepressant discontinuation syndrome should not be confused with the relapse of depression. This is extremely important. How to manage? Well, this is a very, very relevant paper by Jha and Rush and Trivedi, apprised in 2018 in the American Journal of Psychiatry. The typical time is basically something that should occur or onset in a matter of hours or a couple of days after the absolute discontinuation of the antidepressant, especially paroxetine, so antidepressants that have a very short half-life compared to other drugs of the same class. And most clinicians say that this is something that is going to self-remit in a matter of a couple of weeks or maybe 3. The onset may be followed by resolution. The immediate onset may nonetheless be followed for resolution within a much longer period, which may be 6 months up to 1 year. So there's no conclusive evidence, although most of the clinicians usually say that this is going to remit in a few weeks or even earlier. The best strategies is one to reintroduce the discontinued drug and then attempt a much more prudent, slower tapering of the drug. So that's the best idea. And then other approach may include cross titration. So concurrently switching to the new drug while slowly introducing the new drug, and at the same time very slowly tapering of the original antidepressants. A brief trial with fluoxetine should also be a good idea, as I anticipated before, because this is the SSRI with the longest half-life in the class. So fluoxetine, with its main active metabolite, norfluoxetine, allows for the steady state to be reached after 21 days or days, and this is something that we know from the clinical experience also when we have to wash out the patients before prescribing them with the monoamine oxidase inhibitors, which takes 3 instead of the canonical 2 weeks they usually required for the other antidepressants. So slow titration should be the rule. There are some sources saying that this is not that needed. There are no real benefits from slow versus rapid down titration, discontinuation, Well, at the end of the day, I will say that there is no reason to back up the opposite statement. So why take a risky attitude? So it is much more conservative and prudent not to rapidly withdrawal, unless one is worried about very, very, infrequent scenarios. Say, for example, that the woman got pregnant, but even in that case, the evidence here is not present, but even in that case, the evidence suggests to be quite conservative. There's no reason to rush. Or obviously it is very unlikely, but say for example that somebody is going to experience serotonergic syndrome, well, in that case this is a different story. PET imaging data also demonstrate that the occupancy of the serotonin transporter, the 5-HTA, 5-hydroxytryptamine transporter occupancy by the SSRI has an hyperbolicary trend. So it is better to follow a linear approach in the reduction of the drug. Anyway, this is also something that was a source of a matter of vivid debate, and there are different commentaries and letters that follow the paper by Horowitz and Taylor, 2019. This is not presented here for a matter of time. Anyway, so short half-life compounds such as paroxetine should be slow tapered very, very slowly. Whenever possible, the patient should be instructed on what to expect and how to manage. And some patients may be also treated with CBT also for the purpose to increase adherence over the critical period of discontinuation. Education of the patient should be the rule. pharmacotherapy is usually promotes the reintroduction of the discontinued drug, followed by a slower titration, as I said before, or cross-titration, or other agents could be considered, including beta-blocking agents, alpha agonists, long-life benzodiazepines, or antihistamine or antimuscarine, acetylcholine receptor in case of TCA discontinuation, especially when the discontinued antidepressant, the tricyclic antidepressant, featured relevant antihistamine and antimuscarine activity. There are some antidepressants that are theoretically less likely to induce antidepressant discontinuation. Still, we need more evidence, controlled evidence, and prospective studies to test these statements. From a pharmacological perspective, it is possible to expect that buspirone, agomelatine, we saw in the Cipriani review, vilazodone, may be less likely to induce discontinuation syndrome. And this is essentially due to the lack of a clinically remarkable antagonist activity on the postsynaptic 5-HT2A receptor. And on the other side, these kind of drugs are also partial agonists of the presynaptic 5-H1A receptors. We must be very prudent in discontinuing the antidepressants very slowly, especially for people who are very anxious or present endorse a history of panic disorder, poor treatment adherence, high suicidal risk, impulsivity, comorbidities like substance use disorder, or soft bipolar spectrum features. We know that most of the antidepressants and the discontinuation issues are related to the SSRI, but there is also evidence pointing out to this kind of reactions for the older generation drugs. So pharmacokinetics, pharmacodynamics issues are also relevant for this kind of drugs, and yet again, the patient should be involved any time. So, what is the hypothetic neurobiology underlying the antidepressant discontinuation? Most of the effects related to antidepressant discontinuation are those that are being postulated to follow the serotonergic withdrawal, so serotonin neurotransmission. But we know that the administration of NMDA receptor antagonist or dopamine modulators may also affect the HPA axis activity and may ultimately modulate the experience of the antidepressant discontinuation, so the finish symptoms. So possibly there's more beyond the serotonin neurotransmitter. What about the novel antidepressant, especially esketamine? There's no evidence because of the publication bias, simply because this was something that was introduced quite freshly. But the Sustain 2 trial was a discontinuation trial. One of the trials submitted to the US FDA, Food and Drug Administration, for registering purpose, essentially rules out the chance of withdrawal symptoms. Anyway, I will go back to this because among other rating tools, the PWC, so the patient withdrawal and the checklist, 20 items, you see here. I cannot upload more than a few lines for copyright issues, so that's all I can upload here from this paper. So basically, they consider the reemergence of this kind of symptoms as a recurrence of depression for those that were discontinued esketamine after 1 year treatment. Well, at the end of the day, this is an issue that affects many discontinuation trials, and I will go back to this in a minute. So again, antidepressant discontinuation syndrome is not the same as withdrawal. And there's a reason, because people who endorse and prefer the concept of withdrawal are those that they basically say that antidepressant discontinuation underscores the risk associated with that drugs. So basically Fava, Chouinard, the NICE promote this kind of approach. But other authors remark the fact, like Nielsen, that there's no comparison between antidepressant discontinuation and genuine withdrawal phenomenon, as the one that we may expect to see with illicit drugs or barbiturates or alcohol abuse or other drugs that may be followed by tolerance or tachyphylaxis phenomena. So there's also lack of evidence supporting craving, compulsive use, potential overuse or getting high with the antidepressants or most of the antidepressants. Well, there are anecdotal reports about this, but in the clinical reality, most of the evidence is inconclusive and basically against that claim. Moreover, antidepressant discontinuation could be recovered soon after the reintroduction of the discontinued antidepressants, which is something that should not occur with a withdrawal reaction. So this is why I prefer to refer to this kind of phenomenon as antidepressant discontinuation, which is currently the view of the DSM-5 text revision and the American Psychiatric Association. As I said before, relapse is something that should not be confused with antidepressant discontinuation. Basically, you see that relapse means that the same major depressive episode at treatment is going to reemerge with the same symptom that the patient experienced at the beginning of the treatment. So it's the same episode, because there was no time to respond and then recover. No time, usually 6 months or more, depends on the source, for recovery for the index episode. So if it is the same episode, there's no chance to have a recurrence of a new one. So this is relapse. It is important to rely on clinically sensitive operational definitions. Most patients claim that they were not educated or instructed about the potential antidepressant discontinuation reaction. And this is in accordance with a source by Red, 2019, based on the data of an online survey of 752 users in the UK. However, we know that online surveys are prone to selection bias because people that respond to online survey are usually those who experience the problem rather than those that did not experience. So this kind of information should be taken with caution. Anyway, it is interesting to recall that the systematic review by Davis and Red in 2019, that one that promoted, that ignited the amendment and update of the most recent NICE guidelines, concurrently and stratified reported the results from RCTs, so randomized controlled trials, but also observational studies, and then the surveys. And very interesting, the incidence rate, 57.1, 52.5, 50.7% were almost the same. So this means that the online survey matter. And as I said before, multiple times the patient must be enrolled proactively in the process. So future treatment guidelines must include the patient's survey and opinion. The RCT could be followed. I will comment in the next slide, and so prospective longitudinal studies are more warranted. Why RCTs may be prone to sort of bias? Because some discontinuation RCTs, which are basically those that are more considered more relevant for the recommendation for the international guidelines for the long-term antidepressant treatment, are almost entirely based on discontinuation trials. But in many discontinuation trials, the drug placebo difference in relapse rates at the end of the maintenance phase is granted as a prophylactic drug effect based on the reemergence of symptoms which are actually part of the withdrawal symptoms, not of depression. So this is a different story, and this is something that is usually not really accounted in a critical manner. So which is the take-home message here? Again and again, please involve the patient. Please do very slow titration whenever possible. Antidepressants are not addictive, so I'm quite skeptical about the equipoise of the antidepressant discontinuation reaction with those seen for other CNS, central nervous system drugs, because withdrawal is more about illicit drugs, barbiturates, alcohol, or other kind of drugs. It is very unlikely to see genuine tolerance phenomenon with the antidepressant or craving phenomenon, and even the discontinuation of the antidepressant could be recovered quite easily with the reintroduction of the discontinued antidepressant drug. So this is something that should not occur with withdrawal reaction. Antidepressant discontinuation should not be confused with relapse of depression. There's a totally different story. So further longitudinal studies are absolutely warranted, and national-based cohort and community records, like those that are usually recorded in Scandinavian countries, should also take into account the chance of discontinuation reaction for the antidepressants.